Okay, welcome everyone. My name is Susie Adams, and I am a registered nurse, but I'm also the ICD-10 certified trainer for the coding department here at LHC Group. I'd like to welcome everybody to the only broken instrument that works, which is a heart. So we'll go ahead and get started. We have 30 minutes. This is being recorded, so if anyone knows anyone that needs to hear this, it will be uploaded into iTrain once it's completed. So the first thing that I want to cover is, first of all, everyone suffered a broken heart, right? Well, there is actually a diagnosis code for that, and it's labeled broken heart syndrome or Takotsubo syndrome, which is also referred to, or an inclusion term for this, is stress-induced cardiomyopathy or ventricular dysfunction due to sudden emotional stress. Now, we don't really see this a lot, and so, you know, it's not something you're going to be very familiar with or come across a lot, but a few people have seen it recently. So keep in mind that this is one of those diagnoses that is not related to hypertension. And it's not one of those situations where you're going to be looking for the physician to actually document this is unrelated to hypertension. You just have to know that. So make sure that you're not linking this particular syndrome to hypertension. So how would we code it if the patient has this diagnosis and hypertension? You simply would code it with the I-51.81 code and then the hypertension code, and this arrow means that they can be sequenced in either order depending on what your focus of care is. So if there is a behavioral or psychiatric disorder that the physician has deemed is related to this broken heart syndrome, there is no sequencing direction, and there's no code first, and there's no code also conventions that you will see at these codes. But keep in mind it may be added, and one example of that is you may see acute stress reaction, which is F43.0. And then I merely added, yes, I would add it, because, you know, we do consider all behavioral and psychiatric conditions patients may have as comorbidities here at LHC. So I do recommend coding it, but especially in this case, if the patient has developed this particular cardiomyopathy or ventricular dysfunction because of stress or anxiety or anything like that, you want to account for that because it could cause problems in the future as well. So one of the things that I want to go over are the types of MI. The ICD-10 code classification set has separated acute MIs out into the different types. And you're going to see a lot of different verbiage, and you're going to see a lot of different descriptions of acute myocardial infarctions or heart attacks. But this is how the code set classifies them and how they have provided us our codes. And so when you see where I say may use all info to code, that means that anything you see on this page here, if the physician doesn't necessarily say this is a type 1 or a type 2, but he gives this description and says this patient has experienced an acute MI due to an ischemia imbalance, then you can keep in mind that you can use this type of coding or this type of information to pick out your codes. So the first one and the main one is a type 1. And it is due to coronary artery disease and plaque buildup, which causes, of course, acute ischemia or a blockage and prevents the circulation to a particular part of the heart and causes the acute MI. A type 2 MI is due to demand ischemia or an ischemia imbalance that is unrelated to coronary artery disease or plaque. And this just basically could be just a supply and demand situation. Patient needed more oxygen, they didn't get it, so they had a heart attack. A type 3 MI, this is a very serious kind of MI. This is the kind where the patient actually goes into cardiac arrest and presents to the facility, and it's not really, you're not able to identify that the patient actually has had a heart attack until later when the cardiac isoenzymes can be drawn and the blood work can be proven. A type 4 MI is the kind that happens during a cardiac catheterization, stent placement, or other type of percutaneous coronary intervention. And a type 5, this is the kind of MI that will happen within 48 hours of actually open heart surgery. So there are 5 different types, and even the type 4 is broken down further into a 4A, a 4B, and a 4C, but I don't want you to get too caught up in that, because I can tell you right now, these MIs are all coded the same way. So it really doesn't matter. It's just make sure you're looking at this specific information when determining what type, if the physician has not told you. So a couple of quick facts that I want to go over, because there's a lot of discrepancies out there and there's a lot of beliefs that are actually incorrect, and I do get questions about these frequently. So a few things I want to mention. Not all MIs are caused by coronary artery disease. And most of you know this, but I do get questions, okay, this patient has had an acute MI, but I don't see anywhere in the chart where they have any coronary artery disease. Can I assume that? No, you cannot. Just because the patient has had a heart attack either now or in the past does not necessarily mean they have coronary artery disease. Heart attacks can be caused by many things. Acute MI codes do have a time limit. You can only use an acute MI code for 4 weeks. After the 4-week time period, and they do even specify that further down into 28 days, you must then change to an old MI, which is I-25.2 if the patient is experiencing no symptoms anymore, or if the patient is having symptoms, you may use the MI aftercare code, which has now been deemed appropriate to Z51.89. So whenever you're reading these coding tips and you're looking at all this information, they're like, what MI aftercare code are they talking about? Because there is no aftercare MI code. Well, this is the one they want us to use. If the patient is still having symptoms, they want us to use Z51.89 if the MI is older than 4 weeks. Another question I get asked a lot, well, this patient has had coronary artery bypass grafting, and the only reason they would do this is because the patient has coronary artery disease. That is mostly the case. However, someone asked this question of Coding Clinic, and Coding Clinic was very specific to say that just because the patient has documentation of a history of a CABG, you are not allowed to code coronary artery disease unless the physician has actually documented coronary artery disease. So keep that in mind as well. Even though, logically speaking, that's why the patient had a CABG, that is not an assumption we can make. Now, some of you have probably looked at this slide and said, oh my goodness, why on earth would she put EKG strips on a slide? I don't know what I'm looking at. I don't know what this is. I don't want to know what it is. Well, I just wanted some graphics. So, wanted to give you some pathophysiology for type 1 MIs, which of course are the most common types of MIs. I don't know if you can see the difference in these two EKGs, but if you look really, really hard, because to many of you these probably look the same, but if you look really hard, you can see the one on the left, which is the STEMI, or the ST elevation MI. This is very bad. The reason it's very bad, you can see how these things kind of look like tombstones. They call this the widowmakers and the tombstone MIs, because these are very serious MIs, and so if you have documentation of a STEMI, this is the one you want to code, because these are very bad and take priority in coding, and is also the default if a site is given. If your physician says it's an anterior lateral wall, or it's a lateral wall, or it's an inferior wall, or they give these specific sites, but they never really go into what kind of MI it is, you're going to default to a STEMI. A non-STEMI, and I've never had a heart attack, so I don't really know. I assume it's pretty bad too, but it's not as bad. So there's a little bit better recovery, a little bit better chance for the patient, and you can see on this strip, even though there are elevations in the T waves, the top of that curve does not elevate like on the other one. And not that any of that is important, just wanting to show you the difference in the two. And so non-STEMI and STEMIs are both type 1s, but you always, if you have both documented, you're going to default to coding a STEMI. Okay, so let's go over the guidelines and conventions. A non-STEMI can evolve into a STEMI. You will code the STEMI, and you're going to use these codes, I-21.01 through I-21.3. You can also have a situation where a STEMI can evolve into a non-STEMI, and this is mostly the case when they treat the patient with, say, TPA or thrombolytic therapy. It can happen that way. Doesn't matter. The patient still gets credit for the STEMI. Like I said, it's the worst one, the bad kind, so we want to account for that one. If the physician documents that the MI is a non-transmural or a subendocardial MI, you're going to use code I-21.4 regardless of what else they say about this MI. These type of MIs are not ST elevation MIs, and these are very specific kind of MIs, so you're going to use this code if either of these words are used. A type 2 MI, regardless of what kind it is or where it is, you're going to use code I-21.A1. There's no way around this. The reason the first slide, or really the second slide that I showed you, went into the types of MIs, that's what you're going to be coding. You're going to be coding the type if that is documented. So if he documents, if your physician documents a type 2, you're going to code a type 2 regardless of what else is said about it. There's also a convention to code also the underlying cause. And remember, when you have a code also, there's no sequence requirement. So it all depends on your primary focus of care. Now type 3s, 4As, 4Bs, 4Cs, or type 5s, and I cannot wait for the day when y'all actually send me a chart where a physician actually tells you patient had a type 4B MI. It'll be 1 in a million. But if you have a documentation of these types of MIs, there's only one code for all of these, and that is I-21.A9. Now, all of these type of MIs are because of something else, and usually they have to do with an intra-op complication or a post-op complication. So these are your codes, and you will see when you look this code up, it will say you must code first. Either this is a post-op MI, status post-cardiac surgery, or a post-MI, status post any kind of other surgery, or an intra-op MI during cardiac surgery or other surgery. Now, something important I want to mention about these codes. I know they say post-op MI and they say intra-op MI, but that is just for the purpose of this slide. When you actually look those codes up, the descriptions do not say post-op or intra-op MIs. They're actually labeled as a functional disturbance. And yeah, I would agree that an acute MI is a functional disturbance. But don't go looking for a specific code that says post-op MI or intra-op MI. It's going to say functional disturbance. If all you have is acute MI and you have absolutely no other information other than patients had a heart attack, your code is I-21.9, and that's just for acute MI, not otherwise specified. Now, by default, an acute MI is coded before coronary artery disease, but they can be sequenced in either order depending on your primary focus of care. And y'all know what to look for in these charts to determine what the agency or what the physician is wanting the primary focus of care to be. If there's no specific given, you'll code the acute MI before the CAD. But if there is, then they can go in either order. So you can put the CAD before the acute MI. It's not always a requirement that the MI is first. Then we go into I-22 codes, which are for subsequent MIs. Unfortunately, an acute MI is something that can happen and ultimately result in another one within the next 4 weeks after the first one. So they do have codes for subsequent MIs. Now, keep in mind, If the patient has this subsequent MI, there are only specific subsequent MI codes for a type 1 MI or an unspecified subsequent MI. If the patient has another MI, say 2 weeks after the first one, and it's anything other than a type 1 or unspecified, then you're not going to be using a subsequent MI code. You'll have to revert back to using whatever that specified form is. And that when I'm talking about the other form, I'm talking about type 2s, type 3s, type 4s, that sort of thing. I-23 codes are available for very specific MI complications and must be specifically stated as such by the MD. So keep in mind, just because a patient has angina after having an acute MI doesn't mean we're going to code that as post-infarction angina. That is a very specific form of angina, and the physician must state it. So most people in my group know I'm going to include a picture of a baby or an animal or something. So here's my picture. And I think this little kitty cat is saying it just fine for everybody on the phone. We want scenarios. We don't want to go into any more of this mumbo jumbo about pathophysiology. So we'll get to it. Mr. Lovejoy. Patient is being admitted to home health following admission to hospital for a subendocardial MI. The doctor documents that the MI was due to a blockage that affected the anterior wall of the heart. The patient had the MI 3 weeks ago and continues to have unstable angina at times. The primary focus of care is going to be on the unstable angina. So the way that I did these scenarios is a little bit different from the way I've done other ones. I wanted us to work through them together. So what do we need to consider? It's just a few sentences I gave you about the patient. What do we know about this type of MI? I told you that if the physician says it's a subendocardial or a non-transmural MI, that we don't care about anything else. We don't care what wall of the heart. We don't know why. We don't care why. He said it's subendocardial, so we're going to use code I-21.4 for subendocardial MI. So what about the time frame? Well, we're still less than 4 weeks, so we're still good to use the acute MI code. So what do we know about unstable angina and CAD? There is an assumed link, and we will code these together as CAD with unstable angina. So now I know that some of you are going, I don't see where CAD is mentioned up here. Well, we have the MI was due to a blockage that has affected the anterior wall of the heart. That's good enough for CAD. So if you want to make that note, you can. They say there's a blockage in a coronary artery, that's CAD. All right. What do we know about post-infarction angina? Well, he has had an MI. This is angina happening after the infarction. However, that's not how the doctor documented it. So we cannot code it that way unless the MD tells us that's what it is. So what do we know about sequencing for CAD and MI? Well, the default is MI first, but in this case, CAD with unstable angina is the focus. So we're going to code like this. I-25.110, CAD with unstable angina, and then I-21.4, acute subendocardial MI. All right, everything's fine, but let's say Mr. Lovejoy starts to have unstable angina to a point that he returns to the hospital 2 days later. The doctor diagnoses him with another MI. This time it is documented as a type 2 due to demand ischemia from patient's underlying COPD. There is documentation of post-infarction angina. He returns home a week later to resume home health. What do we need to consider? All right, we have 2 MIs. What's our time frame? How many MIs have fallen within the 4 weeks? Well, we only have 1 now, which is our second one. The first one is, and I actually have this written wrong, I apologize for that. It says the second one is over 4 weeks out. That's not true. The first one is over 4 weeks out. The second one is pretty recent. So that's the only acute MI we're going to be coding. Do we have a code for a subsequent type 2 MI? Or did I say only type 1s are unspecified? No, we do not. So we will have to use I-21.A1 for a type 2 MI. Is there a convention to consider at I-21.A1? Yes, there is a code also underlying cause if known. Well, in our Documentation, we know it was from demand ischemia from underlying COPD. So we will code COPD. Didn't say it was exacerbated, didn't say there was a problem with the COPD, just that he has it. How are we going to code the CAD now? Well, since the patient specifically has post-infarction angina now, we will use I-25.118 CAD with other forms of angina. It's not unstable anymore, it's post-infarction. We will need another code will we need another code for the angina? Yes, to provide specificity, so we will use I-23.7. How will we account for the fact that the patient has had 2 recent MIs? So is it important that we document on this patient enough codes to indicate that this is not this patient's first MI? Well, it absolutely is, because there's no way that type 2 MI code says anything about it being subsequent. That's only if it were a type 1. So this patient deserves credit for both of their MIs. There's nothing documented that the patient is having an issue from the first MI. So we will capture it as an old MI, which is I-25.2. Are there sequencing requirements? Yes, there are. You're not going to find them very specifically written out in red notes or red conventions that tell you code first, code also, and all this kind of stuff. But there are coding tips that tell you the order these should go in. When the patient has a complication that is specifically related to the MI and labeled as such, you're going to code that first. So in this case, we have post-infarction angina, and then I coded my type 2 MI, then I coded my old MI, then my CAD with other forms of angina, and then the COPD. Now, Mr. Lovejoy is recovering nicely. His wonderful wife has been caring for him. But suddenly, Miss Lovejoy isn't feeling so well. So we have to deal with Mrs. Lovejoy now and maybe get some more home health in that house to discuss their diet maybe with them. Patient gets diagnosed with a STEMI. They treat her with TPA, and the MI evolves into a non-STEMI. She begins to have dyspnea, and the MD documents that her chronic CHF is exacerbating. He does an echo. He finds a normal ejection fraction, but the patient also has tricuspid stenosis. She also has hypertension. She comes home 5 days later. So what do we need to think about? So what kind of MI are we coding, and is our time limit okay? Okay, she has a STEMI, and she has a non-STEMI. So which one is worse? The STEMI. So we're going to pick that one. And yes, it was only 5 days ago, so we're still within our 4-week time period. Do we know anything about coronary artery disease? We don't know anything. We know they treated her with TPA, but that can treat any number of things. So we don't know if she has coronary artery disease. She's had an MI, she has heart failure, she has hypertension, she has tricuspid stenosis, she has a bunch of problems, but none of them label her with CAD. What do we know about her CHF from the documentation? Number 1, we know it's chronic. Number 2, we know it's acutely exacerbated. The echo says there's a normal ejection fraction. So if the EF is normal, that makes it diastolic. There's also tricuspid stenosis, which is assumed rheumatic. So are there sequencing rules to follow here? Yep, of course there are. So we're going to do our STEMI first, I-21.3. Then we're going to do our hypertensive heart disease with CHF, our rheumatic heart failure, and then our acute on chronic diastolic heart failure. If you're uncertain where I got those codes, make sure that you go back to the scenario, underline everything that's pertinent, and look each one up so that you can see where I got these codes. The stress of taking care of herself and her husband takes a toll on Miss Lovejoy. She gets readmitted a week later with another MI. They take her to the cath lab, and the results show coronary artery disease, so they place a stent. During the cath, they note reduced ejection fraction to 20% with an acute onset of systolic congestive heart failure. She goes home 3 days later. All right, so let's work through it. How many MIs in the last 4 weeks? Well, this poor lady has 2. She's got her initial one and her subsequent one. She has her STEMI, which is I-21.3, that's her first one, and then she has the subsequent one, which they didn't really tell us much about, just another MI, I-22.9. Well, what about the cath? Well, we know we have CAD now, but she does get credit for the catheterization and placement of the stent. Now, in the OASIS, she may not get surgical wound credit, but in her coding, she will get credit. So we can use aftercare circulatory system for this, plus we can account for the CV stent. What do we know about the CAD? Really all we know is it's unspecified CAD. What about CHF? Well, they've changed the specificity on us, so now we have acute systolic congestive heart failure, and we have chronic diastolic congestive heart failure. So we have 2 different kinds because there's not a combination code that is going to appropriately capture the 2 different types the way we need them to. Coding sequence. Well, let's say the primary focus of care is heart failure. What do we know about our sequencing rules? The convention at I-20 through I-25 requires that all codes I-10 through I-16 be coded after them, right? So given that all of these issues are pertinent to this patient and this patient's plan of care, where the heck is that primary focus of care going to end up? All the way down, almost. We're going to have to code our subsequent MI, our STEMI MI, then our coronary artery disease, then our hypertensive heart disease with CHF, then our rheumatic heart failure, then the acute systolic, chronic diastolic, aftercare circulatory, and presence of CV implant. Now, I know we've covered a lot. It's a very fast presentation on a very serious issue. So keep in mind that MIs, they're all case mix codes. They are very important for us to capture if the patient has had one. Make sure that when you're dealing with an acute MI, that you are looking for very specific documentation, as specific as you can get it. Physicians will not always give you what you need, but we do have codes that can cover our unspecified situations. Make sure you're not coding anything that the physician has not said or does not have in documentation that can validate your codes. So a couple of things to remember. The type of MI is more important than where it is. So consider that first before anything else. Use all available documentation to assist in the type of MI identification. Check and double check the conventions at every code being used. Because of sequencing issues, because of guidelines and conventions, you can really get mixed up on how they should be sequenced. And SHP will not always alert you to that. Ask.coding@lhcgroup.com is always here to help. We try to have that manned Monday through Friday, 8 to 5, and we try to answer those questions as quickly as possible. So if you ever have all of this information and you're really not sure, please feel free to reach out to us for any help. These are the references that I used. I hope this has been beneficial. It has been recorded, so as soon as I have the recording link, and it's in iTrain, in our coders group, I will send that link out so that you can either hear it again or you can just review the material or let someone else know that it's available. If you have any questions, please feel free to send them to ask.coding after this presentation, or you may send them to me, and my email is jolie.sykes@lhcgroup.com. Thank you, everyone, for attending, and have a great day.